welcome to all of you. After the legendary talk from Imad Shivan, Ramesh, and Professor Saidur Rahman Khan, practically nothing is left for me. That is why I have become a bit shifted from left main to side branch bifurcation. Okay. Twist and technique, when and where. As Dr. Imad already told, whenever it is essential, you should have to do. So, philosophy will not work all the time. When and where, and let's see some examples. This is a case of LED diagonal bifurcation, ostial diagonal, as well as downstream disease. And this is another LED diagonal bifurcation. And this is another LED diagonal bifurcation involving the diagonal as well as downstream disease. As you know, the bifurcation lesions at or adjacent to a significant division of a major epicardial coronary artery, and there are true bifurcation, non-true bifurcation, all have shown, this has been shown, and all this classification. This picture has not shown, and that is why I have kept here. And whether I shall have to save the side branch or not, if the side branch should be preserved, and only then I shall have to think whether the likelihood of the side branch will be occluded or not. If there is high likelihood, then comes for planned two-stent strategy. Then I shall have to think whether there is 011, there may be stenting, obsolete nowadays, and if emergency, maybe simultaneous kissing, obsolete nowadays, then what else in our hand? In our hand is either T-tap or decay crash. And so, if I want to know if I know two things, one is provisional stenting, another two techniques, either decay crash or T or tap, then my work is finished. I shall go on. And there are guidelines for the treatment of bifurcation lesions. Provisional stenting should be preferred approach for most of the bifurcation lesion, as we know, and exceptions rule are also there. This has also been shown. The side branch, if the dia of the side branch is more than 275 with a long ostial side branch with downstream disease as well as anticipated difficulty in accessing the side branch after stenting the main branch and true distal left main bifurcation. And here, shifting from provisional to two-stent strategy, from EBC main, we know only 22% cases they required second stent. And this year, they have published the 3 years data of EBC main, and they have shown the single stent strategy is superior in terms of target lesion, revascularization than double stent strategy. And these are the side branch. Side branch, does it matter? Side branch angle, does it matter? Yes. Side branch lesion length, more the side branch lesion length, more will be the cardiac death, target vessel myocardial infarction, target lesion revascularization, target lesion failure, and stent thrombosis. It is studied in decay crash 3, decay crash 5, and decay crash 6 trials. And side branch lesion does matter. Another study also they have shown the more the side branch length of the lesion, then there will be the mortality, morbidity, etc. And when two-stent technique, diseased left circumflex or side branch 111 or 101, as I have told, the large side branch, diseased left dominant coronary system, concomitant diffuse disease of the side branch. And provisional versus double stent strategy, many studies investigating the use of one versus two stents in the treatment of non-left main bifurcation lesions, and most of the randomized trials showing no clear advantage of two-stent strategy over a provisional approach. A meta-analysis of these randomized trials show that both strategies result in similar outcome in terms of target lesion revascularization, stent thrombosis, and cardiac death. In addition, periprocedural myocardial infarction are significantly higher in complex versus simple studies. And this slide is also shown, and the two stent strategy regarding the simple lesion and complex lesion, this has also been shown. Here they have shown that in case of complex lesion, you should have to do complex intervention. In case of simple lesion, you will have to do simple intervention. And you know that more than 30%, somebody told in studies that approximately 20% is of left main, and multi-center randomized comparison of two stent and professional stenting technique in patients with complex coronary bifurcation lesion, definition 2 trial, it has already been shown. And if you go for two stent strategy, DK crash is the choice. That has already been told by Dr. Ramesh. And to summarize, if you see a bifurcation lesion, then I shall have to choose whether my patient is of complex lesion or my patient is of simple lesion. If complex lesion, I shall have to do the procedure complex by double stent strategy. If simple, I shall have to go for the philosophy, which I believe for professional stenting. Intravascular imaging is always recommended for procedural planning, guidance and optimization, at least for left main as well as complex PCI. And these are the bifurcation strategies. This has been shown by Imad. If I remain simple, then professional stenting. If I go to the complex, then either I shall have to go for DK crash or any form of crash or T or tap stenting. And let us see how we have managed these branch lesions. This is the LED diagonal lesion, diagonal ostial critical lesion, diagonal length is more than 70 millimeter, diameter is almost, IVAS it showed approximately 2.89, and coronary angiogram also showed 1 lesion. And what we can do, we decided to do a double stent strategy, and we crossed the wire, both the vessel wired, and intravascular ultrasound was done. This is the scenario of the intravascular ultrasound. You see LED MLA is 3.93 and D1 austere MLA is 288. And so, and there is also downstream disease in the diagonal, and that is why we planned for double stent strategy. We planned for a mini DK culotte, but due to the unavailability of the stent, we had to take a bit longer stent for the side branch. It is 3 into 28. And here we have implanted the stent in the side branch, and then first port to the proximal main branch, and then guider recrossed, and kissing balloon, first kissing balloon inflation done, and then second stent LM to LED. This is 3 into 48 millimeter stent was deployed, and then port was done, and then recross, and once again kissing in kissing in stepwise kissing done, and final kissing on the right panel. And this is the third port with 3.5 into 8 millimeter NC balloon, and this is the result after post stent LED prox approximately MSA 15 and LED mid 8.76 and D1 6.93. And this is the angiographic result. You must appreciate the angiographic result, though you are thinking that it is diagonal, a small vessel, but dia is up to 2.93 was only vessel area, lumen area and vessel area become more than 3. And second case, this is you see LED lesion involving the diagonal with downstream disease, most likely more than 10 millimeter, and angle is less than 90 degree, and so we plan to do it a DK crash. And we have done accordingly, wired both the vessels and side branch, lesion prepared both the main vessel as well as side branch, and then we deployed the stent in the, placed the stent in the side branch, keeping the balloon in the main branch. This is one important thing. A main branch balloon should be of adequate size and it should be kept across the side branch stand. If you keep distal to the stand, you may stuck. If you keep proximal to the stand, you may not re-enter. That is the problem, and that is why you should keep it across the side branch stand. Side branch stand deployment is in progress. After deployment of the side branch stand, you see I have kept the wire and I deployed the stand in the main branch. And after deploying the main branch, we recross the wire and do first kiss, and then recross the side branch once again, and this is the second kiss, and after the second kiss we do report. And this is the, on the left panel you see epicranial view, both the vessels LED and diagonal well preserved, and result is very good and appreciating. And this is the final case. This is also once again LED diagonal. Diagonal is also ostial as well as downstream. Whenever we remain within 5 millimeter from the ostium, we do not bother, we do not think, we do not worry. But when there is downstream disease, then we shall have to think twice. Where the, both the vessels, here we have done mini crash, and we have pre-dilated both the lesion, and side branch stent is in progress, keeping the balloon in the main branch. Almost finished, and this is the final. Okay, on the left panel, the main branch stenting, and then report done, and on the right panel, this is the final result. Next. Port, recross to the side branch, final kissing, and report. You see, this is the final result. Those side branch we ignore, but we shall have to think, we shall have to consider side branch. We do not want to lose any branch which approximately 10% gives the myocardium approximately 10%. So we shall have to honor the side branch. We shall have to think double stent strategy. Even then, we are in the philosophy of professional stenting. Then my take-home message, all two-stent strategies have their pros and cons, but no doubt about the need for planning the procedure according to the lesion characteristics and complexity, lesion preparation for a good stent expansion and apposition, and optimization, which is a mandatory and associated with a better outcome, and preferably scientifically evidenced by intravascular ultrasound imaging, by intravascular ultrasound or optical coherence tomography, optimization which is mandatory and associated with better outcome, and appropriate patient selection, operator skills, proper techniques, and image-guided PCI improve clinical and procedural outcome. Randomized trial in bifurcation stenting support the concepts of initial simple procedure with professional, as Dr. Imad told, that was an old concept. But I do with humble submission a bit differ, as because we have seen the 3 years result of EBC main. Even then, we do not believe only on the philosophy of professional stenting, because they have not taken all types of complex lesions, and that is why they are remain within philosophy. Beyond philosophy, there is something which we shall have to think. DK crash appears to be the real deal with best clinical outcomes in true complex bifurcation diseases requiring an upfront two-stent strategy, and image-guided PCI should be considered for left main, bifurcation, and complex PCI to improve procedural and clinical outcomes. Thank you. Thank you all.
Thank you, Professor Jamal Uddin, for your excellent talk on two stent techniques. Professor Jamal Uddin, I have a question for you. Do you hear me? Okay. Basically, you showed first a decay culotte technique and then a decay crash technique. I believe there is some technical issue with decay culotte and decay crash.
Yes.
And I believe there's a study going on comparing the decay crash and decay culotte. Are there similar results are coming up? They have the similar maze or, target patient failures?
That's right. Culotte, practically, culotte has been changed. Culotte has been changed nowadays. Culotte, first change is mini culotte, mini culotte, then added with decay mini culotte. And our aim was to do decay mini culotte, but due to the less availability of the stent size, side branch stent is a bit longer. Otherwise, we have done decay culotte, only decay culotte. Decay mini has not done. So, decay mini culotte is almost equal to decay crash, even though the decay crash is the superior.
So, in summary, in a double stent strategy, always double is better than single. Double billing, double pot, either decay crash or decay culotte.
For double stent strategy, till now, randomized control trial, as we have seen by Dr. Ramesh, DK5, DK6 and DK8 is going on. DK crash is the superior of all double stent strategy.
Thank you, Professor Jamal Uddin.
Collaterals in the side branch, that's very good. As we know, any collateral vessel, any collateral circulation cannot give more than 30% of the supply of that territory. For antegrade supply, if a vessel can give 100%, collaterals can give up to the 30%. So, antegrade circulation is always superior than retrograde or collateral circulation, but sometimes we maintain or sometimes we wait on the collateral supply. As for example, right coronary artery acute old myocardial infarction inferior, right coronary artery is 100% occluded and patient is symptomatic, significant coronary artery lesion LAD, which is supplying the left circumflex. In that case, sometimes we do LAD intervention as because this patient may require CABG, patient denied, or sometimes it is due to the fact that a right coronary artery is, territory of the right coronary artery is not viable. Besides this, right coronary is well collateralized from the left side, so only left coronary artery PCI we do. To me, I want to mean that collaterals, the vessel supplied by collateral is not superior than the antegrade supply.
Sorry.
Dr. Imad, regarding collateral.
So,
Please tell your question, please.
Dr. Imad is.
so I have one comment and one question. The first comment is, there are a lot of young physicians here, so I'm not quite sure that DK crash is the best double stent technique. It is the best one in the best hands and inexperienced operators, but we do need to do a trial that compare DK crash with other techniques in a more broader population of interventionalists, because if the DK crash doesn't go well, the complications are much higher than doing just a T stenting or a simple culotte. So I'm not quite sure that we can generalize that DK crash is the best, because we haven't seen these randomized trials in other places of the world that was not in China. So I think we have to be a little bit careful, because if you say, I'm going to do DK crash in every single double stent patient, and you are not an expert operator, you are going to have much worse outcomes than doing simpler ones. So perhaps for everybody, is the one that you are more comfortable is the one that probably is better. The second one is more of the question for the opinion of the panel. So there are two different concepts. One is, what is the best strategy to define whether we want to prevent restenosis of the side branch versus whether we want to prevent an acute occlusion of the side branch? And in determining what it is the complex bifurcation that requires a double stent, I think we have to understand what we are preventing. If we are trying to prevent the acute occlusion of the side branch, or we are trying to improve the long term of that side branch, which in general, if we did not put a stent in there, the outcome, other than angiographic restenosis, in general is a good outcome. Whereas if you put a double stent, you can have a much more severe complication with the stent thrombosis. And that is a question, what are we defining a complex bifurcation for double stent, and what are we talking about?
Actually, we are running very short of time. So, a single question. Sir.
Dr. Imad will.
No, actually, I totally agree that the DK crush is a very excellent approach for two-stenting, but I do not agree that it today, at the present time, is the best one. Because I think that we have improved all two-stent approaches. We have improved the stent platforms. We have realized many things from bench testing that we introduce in clinical practice. What have been done in the past was comparing the old fashion of culotte with the more advanced technologies, as well as T-stenting, as well as other two-stent strategies. So today what is lacking is data comparing the modern approach with culotte, with DK crush, with modified T-stenting and so on. And this is still lacking, and we need more randomized study dealing with complex bifurcation all and comparing these procedures in this subset of patients. The second point is about the restenosis on side branch or total occlusion. I mean, of course, that we have learned that recoil is very important. If you do not have stent, even with drug-eluting balloon, you might have more recoil. So stenting is, I think today, is the best way to deal with tight stenosis on side branch on an important, clinically relevant side branch. But of course, what is coming from many studies and randomized studies that like EBC main, that's no difference using one stent against provisional stenting in simple bifurcation. So if we are dealing in simple bifurcation, I think still provisional stenting be the winner.
Thank you, Dr.
Ramesh.
Imad.
I think in
Dr.
view of
Ramesh.
time, yeah,
Thank
I
you.
think in view of time we need to move forward. But I'll just tell for the group here, if you want to prove that your stent technique is better, you have to fight against the DK crush.
Yes.
Even though it is done in China.
Actually,
it
so
is
many
a-
debates would be there, but we are running short of very
Wait,
time.
wait,
So,
Right.
we can.
I want to
Yes.
say last.
Okay, one more,
sorry,
please.
Ramesh, you are right. So far, DK mini crush is the best, but DK mini clot would be better because carina coverage is much more better than DK crush and could be easier to do it. So I'm doing double kiss mini clots last 1 year. So I believe that the result will be better if they compare it in randomized style. So
Only problem is
Thank
that
you.
there are many steps, and we shall have to do the procedure effectively, and it should be evaluated by imaging.
yeah, but steps is
Thank you
is
very
the
much.
same as DK mini crush, and it's easier to recross, side branch.
DK mini culotte.
Yes.
Actually, debate will be going on. So, next presenter.